definitive approach in managing hypertension in Indian patients case scenario. Next. So half a century ago, most of the clinicians believed that rise in systolic blood pressure in an advancing age was a benign physiological response to age-related arterial stiffening. So, systolic BP was believed to be normal as long as it did not exceed 100 plus of your age. Thus, 70 years old women with a systolic BP of 170 did not need a treatment. That was the concept. If you see in one of the journal, if you try to reduce the BP, they used to say it's like a sin. Next. So as you see, this greatest danger to a man with a high BP lies in its discovery, because then some fool will try to reduce it. This was the old concept way back, almost like 3 decades ago, 3 to 4 decades ago. They used to think that reducing BP was like not necessary. But however, the recent guidelines, ESC guidelines, ADA guidelines have given very clear cut, even in an elderly patient, geriatric age group, you need to have a target BP. Next. So this is what is called as a healthy topics, where I have and my team have come up with a good concept where people, general public, they can access health related videos. Whatever you are seeing on the that is QR code, it's a QR scan to get directly connected to the healthy topics that is available in the YouTube. You get we have uploaded nearly 30 to 35 videos related to non-communicable and communicable diseases. Hope this QR scan will reach more people, and because our India is very poor in health management. So beside QR scan is a link to open this channel. Okay, because why this social media is very important nowadays is most of these youngsters or young generation, they are in hurry to face this world, so they are under more stress, and most of the people, they don't have time to access these health issues. So this is the social media platform where people can access more health related issues. Hope this QR scan reaches more people, and you can even scan this code where you can easily open this direct link to this YouTube channel, Healthy Topics. Next slide, please. So during my post-graduation days or my MBBS days, they used to tell that BP reduction of 10 millimeters decreases the risk of cardiovascular. However, now the trend has changed and the guidelines have changed, saying that even the reduction of 2 millimeters decrease in blood pressure reduces the cardiovascular events by 7 to 10%. That's a very important slide from this, where because 7 to 10% reduction in cardiovascular events is a huge improvement in reducing 2 millimeters of mercury. And you can see the slide that 10% risk of mortality is also being reduced in stroke, 7% reduction in ischemic heart disease. Next slide, please. Next slide. So this slide is very important. Stress on health. See, nowadays more people are under stress, maybe due to their work or due to their family or due to their debts or in the education. We see more and more youngsters getting diagnosed with hypertension, that is age less than 30 years. So if you see this, the slide, 20% hypertension, and if you see that blue sector population, which was normal, is only 19.5% among them. If you see 39.8% found to be pre-hypertensive stage, and 40.7, the green one found to be, the orange one is hypertensive and the green one is pre-hypertensive. You see, these pre-hypertensive, if they don't have a proper health education or proper lifestyle modification, they can switch on to the green sector and they can get to be a hypertensive stage. So here from this slide, it's very important to address the lifestyle modification for hypertensive patients. So risk factors, if you see, 70.8% carries obesity or overweight. However, the smoking is around 10% and 33% is due to our disease of India, that is diabetes. So 75% consumed alcohol. So all these risk factors amounts to be modifiable risk factors where you can target pre-hypertensive patients where they can have a very good healthy lifestyle and they can control the BP. Next slide, please. So hypertension is a major public health issue since this hypertension is a systemic disease. It can affect any organ in our body. Predominantly, major organs include cardiovascular, cerebrovascular, renal. These are the very drastic changes that happens if you don't control blood pressure. And there is one more rule called the rule of 50. What is this rule of 50? When I was doing my MD post graduation days, out of 100% population, only 50% get to be diagnosed hypertensive. Among that 50%, another 50% takes the treatment. Among that, another 50%, they are going to stick, that is, have a compliance to the drugs. You see this very negligible patients are on the treatment of blood pressure. That's why measurement of BP in a clinical practice is a very important in day-to-day practice. So you see, if you see this slide, in India, number of hypertensive individuals is anticipated to nearly double from 118 million in 2000 to 214 millions by 2025. That is another next 2 years. The only reason and the main concern is what you say is they are unaware of blood pressure measurement. They are unaware of the drugs and scared of taking this antihypertensive drugs lifelong. So these are the many. There are many pros and cons where you cannot have a very good compliance for controlling the hypertensive patient. Next slide, please. Next slide. Previous slide. Okay, so let's come to the case presentation. We discuss only one case, that is 48 years old man presents with uncontrolled BP upon routine annual checkup and monitored through hospital BP measurement, home monitoring BP as well. Upon examination, BP is 160 by 85. It is quite high. Resting heart rate 95. This is also within normal range. However, it is on the higher range. And ambulatory BP measurement was advised, which revealed morning hypertension 145 by 85. That's also a bit high. Annual health checkup revealed creatinine 1.1, estimated GFR 85, total cholesterol 289, HbA1c 7.1. So personal habit, smoker since 18 years, occasional intake of alcohol, runs a family-owned business, sedentary lifestyle, has a disturbed sleep, is obese, weight 95 kgs, family history, positive for hypertension and coronary heart disease. Let's see this slide. Please don't change this slide. So this is 48 years old man, is not bit quite old, though it is 48 years old. And on routine examination, you have two BP measurement. One is the hospital measurement 160 by 85. Another is the home measurement 145 by 85. So there is quite fluctuation in this BP from this slide. Second, heart rate is at the higher range. So creatinine looks normal, estimated GFR looks okay. Cholesterol looks deranged, dyslipidemic picture with elevated HbA1c level. However, his sugars are not been mentioned in this slide. If you see the personal habit, is a smoker. Smoking per se is a related term to cause elevated BP. So if you see this slide, the patient known smoker, whenever you check the BP for this patient, so you should ideally advise that patient to stop smoke at least 24 to 48 hours before checking the BP. That's a very important message from this slide, because you are going to diagnose, you do false diagnosis of hypertension in this patient, because this smoking per se, the nicotine whichever is present, it is a cholinergic. So it increases the heart rate, it increases whatever you are seeing, the resting heart rate 95. So it should be mentioned whenever you check the BP, patient has been stopped the smoking from. So we have a very clear cut. That is, it is an ideal BP checkup. So occasional intake of alcohol per se will cause a rise in heart rate and alcohol. Again, it should be have abstinence from alcohol 24 to 48 hours before checking the BP. And family owned business per se will cause a lot of stress. Sedentary lifestyle, yes. And disturbed sleep, yes. It increases the sympathomimetic activity. And obesity, again, another risk factor for hypertension. So family history positive for hypertension and coronary artery disease. So from this slide, you have a lot of issues to be addressed to this 48 years old man. So let's get into this topic and let's drill this question in depth. How do you need to control the BP in this 48 years old man? Next slide, please. So understanding of the heart of the matter. Okay, next slide. So, what are the concerns in young hypertensive patients? Whenever you diagnose hypertension in young, you should need to have certain important key findings in your brain. One is renal function. Second, any association endocrine related problems. Third, is there any end organ damage? That's the three things you should need to have a concern in a hypertensive patient who is young. So, young hypertension, you need to have a target BP, and if you have a mild renal damage, you should add a mild renoprotective measures to be taken, and lifestyle and family history to be addressed, and heart rate and morning hypertension. Heart rate is very important because heart rate per se will increase the systolic blood pressure, and it causes a decreased blood flow to the cardiac. So patient can have minimal ischemia. Okay, next slide, please. So if you see this resting heart rate 95 and BP 160 by 85 from this slide, let's get into depth of this. So next slide, please. So there was a study, 15,000 young patients diagnosed with hypertension. The study was a real young hypertension study. So patient diagnosed, there was two arms. So more than 50% of the patient with hypertension has a sedentary lifestyle, and the patient diagnosed with only hypertension were 29.1%. Next slide, please. So if you see, next, Priya, yes, hold on. So if you see this slide, real young study, hypertension study, if you see this bar chart, the green one shows two arms, that is the dyslipidemia and diabetic mellitus. There is no axis, x-axis, y-axis, nothing represented. However, if you see this dyslipidemia, the diabetes will take the more upper hand compared to dyslipidemia. And if you see the hypertension history, this patient, I think it is carrying more than 50%. So diabetes and hypertension carries more risk factor in a young person. Next slide, please. So 75% with hypertension in India have uncontrolled BP. That is Lancet study stands. So it's a quite alarming message for a general public, where you need to have a regular BP checkup whenever a patient with more than 35-40 years, and our diet, Indian diet, is more spicy, more salty. Better have a regular BP checkup. Okay. So next slide, please. So this heart rate and the sympathetic drive has what do you say? It's a positive effect. If heart rate increases, the increased contractility will increase, increased resistance will increase. That causes increased blood pressure. What happens when heart rate increases? You have a non-adrenaline and adrenaline, which causes RAS activation. This RAS activation will cause sodium retention at the kidneys, and it increases the blood volume, it increases the blood pressure. Next slide, please. So you need to have a sympatholytic drug in an young hypertensive patients. Next slide. So elevated heart rate, what are the effects that causes, what are the things that can lead to 1 second. Yes, elevated heart rate per se causes a lot of changes, that can take place at the cardiovascular. One, it increases the atherosclerosis, and it causes endothelial dysfunction, and these atherosclerosis will lead to the ischemia and causes remodeling, chronic heart failure. So you need to have a heart rate control in an young hypertensive patients. Next slide. So how do you this heart rate because these are the effects of cardiac on heart rate. Next slide. So you see this slide. 6 out of 10 newly diagnosed hypertensive patients in India have sympathetic overactivity. So that's why whenever you measure blood pressure, you should always have a look at heart rate. So especially in young patient who has more heart rate, you need to have a drug that controls BP and is also heart rate. That is a sympatholytic antihypertensive. That's our calcium channel blockers. Next slide, please. So, what can trigger the sympathetic overdrive? So, you have 5 causes: diabetes, mental stress, obesity, smoking, hypertension, as we discussed on the previous slide. Among them, diabetes and hypertension per se, we have a vicious cycle which increases the heart rate, and this causes increased atherosclerosis. Further, hypertension is increased. So, you need to break this vicious cycle. Next slide, please. So coming to the HbA1c, 7.1% in this patient is a quite high because you need to have a target HbA1c in a non-diabetic patient. That is, it should be less than 5.5 according to ADA guidelines, recent ADA guidelines. However, it can be taken less than 6%. So next slide. So this diabetes and hypertension, when the diabetes part has been included in an hypertension patient, they can go for what is called premature atherosclerosis, where there is increased risk of cardiovascular disease by 75%. Next slide, please. So characteristic of high sympathetic overdrive in youngsters. Next slide, please. So they'll be anxious, panic, nervous, insomnia, inability to relax, palpitation, higher heart rate, and dyslipidemia. I think more and more people in my clinical practice, we see patients ಬರ್ತಾರೆ ಸರ್ ಬಿ ಪಿ ಫಾದರ್ ಮದರ್ಗೆ ಯಾರಿಗೂ ಇಲ್ಲ ನನ್ಗೆ ಹೆಂಗ್ ಬಿ ಪಿ ಬರುತ್ತೆ ಅಂತ ಕೇಳ್ತಾರೆ. ಸಿ ಯು ನೀಡ್ ಟು ಕೌನ್ಸಿಲ್ ದ ಪೇಷಂಟ್ about the first BP recording and need to advise first is lifestyle modification. Don't straight away shift to the drug therapy. You just tell them and you ask what are the ideal thing you have measured the BP. That is, patient should be sitting calm, his bladder should be empty, he should not be have any food like half an hour before, should be stop smoking and alcohol 24 to 48 hours before. So after all these things have been ruled out, he got high BP, please sit with him and talk to that young guy who have been diagnosed with hypertension. Next slide, please. So what are the most global guidelines recommended is sympatho inhibition as a goal in antihypertensive treatment. However, older sympatholytic drugs like clonidine as rebound hypertension. However, the newer molecules have causes a drastic improvement in young hypertensive patient. If you do a sympatho inhibition, if you see this slide, there is an increase in cardiac and vascular protection. And also, there is a lot of advantages. It decreases the BP, it decreases the insulin resistance, which is an add-on benefit for a diabetic in a young patient. And also, it decreases the coronary vascular resistance, heart rate, and myocardial oxygen demand also is reduced. Next slide, please. So coming to the creatinine for a young patient, where you need in any young patient less than 35 years, please kindly don't add AC inhibitors or ARBs for controlling hypertension, because you need, God's sake, you don't know whether patient is having renal artery stenosis. If you add AC inhibitors, ARBs in patient, you are going to end up in acute renal failure. So ideal drug of choice for an young hypertensive patient is calcium channel blockers. Next slide, please. So you have a number of generations for calcium channel block. The most commonly used is 4th generation cilnidipine, 3rd generation amlodipine. Okay. However, nifedipine, though useful, we discuss about cilnidipine. Your molecule short acting, okay, and have a very good duration of action around 8 hours. Next slide, please. So heart rate control and cardio protection, the newer CCBs. What is the role? Next slide. Yes, next slide. So this you have calcium channel blockers of 2 types. Calcium channel basically have L type and N type. L type, which causes vasoconstriction, release of calcium. When you antagonize this L channel, it causes the vasoconstriction effect is nullified. So when you have a L and N-type calcium channel blocker, you have an extra benefit, that is the renal vasodilatation. Along with it blocks norepinephrine release, which causes sympathetic activity and also causes a decreased tachycardia and causes less pedal edema. This is a very beautiful molecule compared to your third generation amlodipine. Next slide. So if you compare on this, if you see this, what do you say, the duration of action in cilnidipine, which has very short onset of action, that means you need to have a quick BP reduction in an young patient, and patient is on more running here and there day-to-day activities. If you see this, suppose it's a guy who's sitting in IT sector in a Bangalore or in some metro cities, he is in the rush. So you need to give a very good molecule which acts with very short duration of action. I think we can go with cilnidipine, that is 2 hours, within 2 hours, and also has the duration, short duration, 8 hours duration. So you can add BDTID dose. Along with that, they both have a good, all three these molecules, nifedipine, amlodipine, and cilnidipine, have a very good BP reduction. However, if you see this pedal edema, it is only 2.5% compared with amlodipine. Proteinuria, it's another benefit for renal protection, because since it reduces, and the dyslipidemic patient also you can give it. It is both a L and N channel blocker. Next slide, please. So cilnidipine, yes, I regularly use in my clinical practice, and a very beautiful molecule to be given to the young patient, unless you don't have bradycardia, because since it reduces the heart rate, you see patient who is whoever is bradycardia, you don't give this molecule. Next slide, please. So if you see this slide, when it is compared with cilnidipine, amlodipine, and benidipine, if you see this SBP, heart rate, and percentage of change of plasma norepinephrine, if you see this on the first line graph, you want to reduce the BP. All drugs are reducing the BP. If you see the slide that everything is going down, you see that's going down. Same thing with heart rate reduction. If you see this amlodipine, it's actually increasing the heart rate. Benidipine is increasing the heart rate almost, and nifedipine is also increasing heart rate with reducing BP. So it's not an ideal choice for an young patient. That's why if you see this slide on the cilnidipine, though still norepinephrine levels have not risen. If you see the other amlodipine, benidipine, and nifedipine, it's quite increasing, though it has an anti-hypertensive effect. Whatever the norepinephrine levels, noradrenaline levels are increasing. So I think we can go with, yes, I use regularly, and it's a beautiful molecule. Okay, you can start with 5 mg, slowly you start with 5 mg BD or 5 mg OD, slowly monitor the BP, and as the dose can be adjusted, 20 to 40 mg per day. Next slide, please. So, this is, as we discussed previously. There was one of the study, Achieve One study, which was ambulatory blood pressure control, and home blood pressure monitoring morning and evening was done. And they have recruited 2,319 patients. Cilnidipine was given once daily in the morning, 77.3% of the patient. In the evening, 11.5% of the patient, and twice daily in the morning and evening. With a mean, so definitely there was a positive reduction of heart rate and BP on cilnidipine. Next slide. So this is the same thing as we previous study has shown. There is definitely important reduction of heart rate and also control of noradrenaline levels in the blood in an young patient, which to be addressed while controlling the blood pressure. Next slide, please. So this is the Achieve One trial done. Yes. Next, there is another few journal, JCH journal. They have given conclusion that in patient with essential hypertension, cilnidipine suppressed cardiac sympathetic overactivity, whereas amlodipine has a very less effect. Yes. Next slide, please. So effects of amlodipine and cilnidipine on cardiac sympathetic nervous system and neurohormonal system, definitely cilnidipine is superior to amlodipine. Next slide. Yes, definitely. If you see this slide, that is amlodipine and cilnidipine. If you see this norepinephrine level changes from before and after the treatment, definitely cilnidipine is superior to amlodipine. Next slide. So if you see the BP variability with cilnidipine compared to other drugs, you see the graph, it's very much negligibly variable of the BP values of patient on cilnidipine. Next slide, please. So cilnidipine is novel rhinoprotective sympatholytic antihypertensive that should be given in an young patient. Okay, so definitely it's a very good molecule. Okay, next slide. So other beta blockers, you have a very selective beta 1 blocker, metoprolol, esomeprazole, and acetylbutol. So though beta blockers are still given in a young patient, but don't add beta blockers just casually, because these beta blockers are to be added in a patient with established heart failure or established coronary artery disease. Suppose a patient ಯಾರಾದ್ರೂ ಒಬ್ರು ಬರ್ತಾರೆ, ತಲೆನೋವು ಇದೆ, ಸ್ಟ್ರೆಸ್ ಇದೆ, you don't add BP ಜಾಸ್ತಿ, you don't add beta blocker just casually, because the only guidelines says that beta blockers should be added in a coronary artery disease for remodeling, for controlling heart rate. Yes, next slide, please. So that's the young hypertensive with grossly uncontrolled BP. You have a beta blocker with, usually you start with calcium channel blocker. You have any other risk factor, you can add a beta blocker. And always have a concern about discussing lifestyle modification. That plays a very important role in controlling BP. That's the key message from my topic. Next slide. Thank you. So, ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. Giving me this opportunity from JB Pharmaceutical. Thank you one and all.
Thank you so much for giving this wonderful presentation. I'm sure that many doctors will learn something from this side. And moreover, sir, you explained sentence by sentence and everything clearly and beautifully. I thank you so much for your valuable time and for presentations.